Assalamu alaikum, hello and welcome to yet another special episode of Health Show Live Surgery, here only on the Islam Channel. Now, if you're tuning in for the report, it will be screened at 10 p.m. tonight, so you'll still be updated on all the latest news for today. Now, so far in the Health Show Live Surgery series, we've brought you live laser eye surgery, ankle surgery and hair transplant surgery. And on tonight's show, we'll be delving into the fascinating world of cataract surgery. But before we reveal any more, let's show you a quick recap of our last show, which was on hair transplant surgery.
So she's harvesting the grafts from the areas that she's actually calculated, she's designed for where she's going to take the grafts from.
So they're all stored in this sort of pen-like device, are they?
No, so she's actually making little punches within the actual, around the graft, so that when she comes to collect these grafts, she'll collect a dozen grafts at a time. So at this moment in time, the grafts are almost released from the dermis layer, and then she'll get the appropriate tool to be able to take these out and then store ready for the implantation process.
Okay, so we'll let the audience and everyone at home into a little bit of a secret now, because you've actually undergone the procedure yourself, haven't you?
Absolutely.
And at which point everyone now looks at your hairline to see how good it is. Wow, it really was remarkable to watch how those surgeons extracted each hair follicle one by one and then having to place them directly into the area of hair loss, which, as you saw there, takes incredible concentration. Now, if you're considering having hair transplant surgery or would like to find out more about hair loss, then please email us on healthshow@islamchannel.tv. Now, on with tonight's show. Imagine waking up one morning and having cloudy vision. Well, as our body ages, it requires regular maintenance. The eyes go through a lot on a daily basis, which is why it's important to make sure that we actually look after them. Now, joining us in the studio this evening, we have our audience, who, along with you at home, will get to watch a cataract surgery. Our guest is Mr. Badrul Hussain, a consultant ophthalmic surgeon at Moorfields Eye Hospital, who carried out the operation that we're going to see later this evening. Now, Mr. Hussain will talk us through the surgery and then answer your questions later on. We'll also be hearing from our patient, Sylvia Hyde, who's had a successful cataract surgery, and see how her recovery is going as well. But first, let's find out a little bit more about Moorfields Eye Hospital and follow the patient's journey there.
Management of staff at Moorfields has changed significantly over the years and has improved a lot. There's an annual staff survey that covers all NHS hospitals and trusts, and Moorfields always scores very well in that. And in fact, in the most recent survey, the overwhelming majority of our staff said they would recommend Moorfields both as a place to receive treatment if they needed it and also as a place to work, which is a really positive thing for us.
Moorfields is quite a big hospital, and it's not just the main site we have in London. We actually see patients in 32 sites in and around the south and southeast of England. We offer all sorts of what one might call routine care for the eyes, things like cataract surgery, treating children with squints and lazy eyes, and looking after people with retinal problems. And we also do some very highly specialised work with rare conditions and conditions that really can't be looked after by other hospitals in the country.
It's a specialist trust. We deal only with eyes, but it's also a trust that has grown in a rather interesting way. We're all here to support patients, and even the back office functions like HR are there to make the lives of our clinical staff who look after patients easier.
I was first told I had a slight cataract when I went for a routine eye test. Didn't really notice that I had any visual loss at all. While we were talking, he asked me if I'd ever had my eyes examined or about the last time I'd attended, and he told me that he could refer me to Mr. Hassan, and the appointment came through for me to come and see Mr. Hassan here at the clinic.
It's actually quite difficult to completely prevent cataracts because there is some clouding of the clear lens of the eye as everybody gets older, and if we all live to 200, we'd no doubt all get cataracts. And some of it is genetic, and there's really very little that you can do. But there are some things that we can do to protect our eyes. For instance, if you're out in very sunny environments, very bright environments, it may be helpful to wear dark glasses to protect your eyes. It's absolutely crucial to make sure that nutrition is good. So a good healthy diet rich in fruit and vegetables, and if you're not got a very good diet, considering vitamin supplements all may help. But there's nothing that can absolutely guarantee that you won't develop a cataract.
When I met Mr. Hassan, he said that I had cataracts in both eyes. He told me the risks of the surgery, and I was quite happy having met him and had all the tests, so I was quite happy to go ahead. The team here at Moorfields gave me a letter. They explained what the procedure was and what Mr. Hussain wanted. That's the first time that I've experienced that attention to detail.
We see a lot of patients, and I think our services are busy, but they're very caring, and I think what's great about Moorfields is we're really able to offer care for all diseases. Everything from the very simple to the very, very complex is available here. Sometimes people can put off the day of surgery for quite some time, and occasionally forever, by having up-to-date glasses, by adapting their lifestyle. For instance, some people who decide not to have surgery may decide not to drive at night, and from support with their family. Having said that, the risks are pretty low. It is a great operation, and people shouldn't be fearful because it can make a huge difference to people's lives.
I have the admission date, and I've put that in my diary, and I'm absolutely terrified. I'm talking to everybody, which is uncharacteristic of me. It's not the pain, it's not the thought of even the loss of vision or the success or otherwise of the surgery. It's just the idea that somebody will touch my eyes, and I have every confidence I'll stop them. I'm just absolutely convinced that I won't let the surgeon touch my eye, so I can't see how the surgery is going to go ahead.
We'll talk to Sylvia in a moment, but you can certainly tell from watching that clip there that there's a strong foundation and a great sense of care at Moorfields Eye Hospital. And as someone who wears a pair of glasses, I know that how taking our vision for granted can affect us in our daily life. So it's really, really assuring to know that we have such a great institution with the NHS there to help us. First of all, Mr. Hussain, I want to talk a little bit about you and how you become an amazing eye surgeon. That's obviously a long journey, a long training period. Roughly how long are we talking about?
For me to become a consultant, I think I started my ophthalmic training in 2001, and I became a consultant 4 years ago, so almost 11 years.
And what made you specialise in cataracts? Because obviously you probably had lots of choices of lots of areas where you could have gone to it down.
The thing about cataract surgery is it's almost, I won't say instantaneous, but usually by the next day the result is visible. And in terms of changing people's lives, you know, a lot of the patients I deal with present very late and are effectively blind from cataract in this country. So the next day they're seeing.
So it is really life-changing stuff.
Yeah, it can be.
And so tell us a little bit about a cataract. What exactly is a cataract? Because we're all familiar with the term, we understand it's this sort of clouding effect, but what exactly is going on in the eye?
Okay, well, I'm just going to use this little model. Give me 1 second. So, if you imagine this is an eyeball, the clear window at the front of the eye is like a little chamber, and behind it is the iris, the coloured part of the eye. And if I take these away, behind that is the natural lens that helps to focus the light in the eye. And what I liken it to patients simply is it's a little bit like a Smartie, but instead of a crisp shell, it's got a very thin capsule, like a little membrane covering it, and inside there is the actual lens substance. Now, when we're born, it's crystal clear, but as we get older, just like our hair whitens...
I noticed you looking at me there, thanks for that.
Yeah, exactly. Just as hair whitens and we all get wrinkles if we live long enough, the lens itself starts to become cloudy. That's just an aging process, very little that can be done to stop it or reverse it, but you can reduce the progression, as you saw in the video talking about good health. But one of the things that I always say to patients is, you've got early cataracts, if you stop smoking, you might delay surgery by a year or two. Because smoking, as well as all the other bad effects, people don't appreciate it has a lot of impact on the eye.
Now, while you've got the model there, we're going to see obviously the operation shortly, but very briefly, tell us what the operation involves.
Okay. So, I knew that was going to happen. It's a little bit fiddly. So I'll put these to one side. So, if you imagine the lens, as I said, is like a little Smartie, and it's suspended by lots of little tiny ligaments within the eye itself. What we do is we make an opening in the membrane at the front, and we suck out the chocolate in the Smartie, leaving the shell behind. And that then supports a lens implant. Once we take the substance of the lens out, the focusing power of the lens goes. So we then have to replace it with a lens implant. And the good thing is we can choose the power of the lens. So if somebody wears glasses before surgery, we can build their spectacle prescription to either give them good distance for far away without glasses, or if they prefer, if they're a painter, they want close-up vision without glasses, we can decide what the power of lens is with the patient. So, and again, customise that to the patient.
Now, we heard there in the video about Sylvia, so I want to actually turn to Sylvia for a second.
Sure.
And Sylvia, talk to you about, we heard there at the very end, you admitted your fear and that you were really, really frightened of the procedure. What was it that was really getting to you?
I think it was that I couldn't conceive how I would allow the surgery to take place. Pain wasn't an issue. I thought that I'd be given pain relief, which I was, but it was just the idea that I couldn't just tolerate the idea of somebody approaching, or the surgeon approaching my eyes, just for anybody to touch my eyes. I'm timid about anybody sort of looking into my eyes about...
I'll look this way then quickly. But actually that whole thing of people being afraid, there is something about our eyes. Yeah. And obviously I presume this is something which is very common, that people are petrified.
People are petrified. I mean, you know, if I came close to you with your eye, your natural reaction is to flinch back. Yeah. The eye has got, you know, an abundance of nerve fibre, so if you've had an eyelash in the eye, you know, it feels like you've got brick in there. So I think it's a natural, inherent sort of response. If something comes near your eye, you're going to move away.
So a huge part of your job, I guess, is reassurance, is it?
It is. And a lot of the tests that we do in the clinic, things do come close to the eye, and that's a gauge of how we, you know, gauge how the patient's going to behave. So if we can't get anywhere close to them, which we usually can, so most people for cataract surgery are awake.
So we're going to go through the preparation part in a moment. We've got a video to show that. But we talked a little bit about that. We heard about Sylvia, how she had an eye check and she found out. What's the most common way that people realise that there's a problem?
I wouldn't say they have a problem. One of the commonest ways is people go and visit their optician. Their optician does an eye test and they say you've got cataracts. What the underlying reason for them being referred to hospital, I would like, from most people, is to say what's causing them any problems. So if they've got no problem, an early cataract can be left alone, updating their glasses. And we only operate on people once their vision is troublesome, once it's impacting on their lifestyle. So if somebody's sitting, you know, their general lifestyle is sedentary, they're at home watching TV and reading books, they might not need surgery for a while, whereas somebody else who's an active lifestyle, who drives at night, that's a very common symptom, being dazzled by headlights.
Because we talked there about the pre-surgery, and actually we're going to go and have a little look about that, because when we think of hospitals, we do tend to have these preconceptions about what a visit might entail. So we thought it might be really useful to help alleviate any concerns you may have by showing you what's involved in the preparation stages of cataract surgery.
So, Mrs. Nazim, I'm going to clean the skin around your eye first of all. Drawing up some local anaesthetic. Now I'm going to dry the skin. The next thing is a little gadget that holds the eyelids open. So if you can open your eyes for me, that's good. And look a little down for me. So this can feel a bit strange. It just holds the eyelids open. And we put another drop of the local anaesthetic just onto the corner of the eye. Now, you will feel some pressure around the eye as the anaesthetic spreads around. This takes about 20 seconds to inject the anaesthetic around the eye. Are you okay? Doing very well. I'm going to take that clip from between your eyelids. Now have a little look, see how that's starting to take effect. Now if you can open both of your eyes wide, so the right eyelid is already starting to relax. If you look over to the left and over to the right and up and down, so most of the movement's already gone. So that's already working well, and that's it. We can take her through into the operating room now.
There'll be lots of fresh air underneath. Your job is to keep breathing as normal. Feels a little bit strange for the first few seconds. After that, you should get used to it, okay? If you bring your chin up for me a little bit, that's lovely. So just cleaning around the eye. Make sure everything's nice and clean. Both eyes open for me now. The right eye may not open because of the anaesthetic. Both eyes open, looking down for me. Now, I'm just going to ask you to keep looking down while I get this over your face, keeps everything nice and clean. There we go. So, just for a few seconds, bear with me, keep breathing as normal, don't hold your breath, keep breathing. Lovely. How are you doing under there? Are you okay, Miss Nassim?
Yeah.
Good, good, good. So, going to put something in just to hold the eye open, and then we'll start the operation, okay? Just making a little hole in the plastic so we can get to your eye. Okay, Miss Nassim, we're just going to pop something in to hold the eye open, same as before, except you shouldn't feel it as much now because of the anaesthetic. We're going to bring the microscope over, so what you'll see is that the microscope shines onto the eye, and then we get a view, very magnified view of the eye, which is shown on the screen up there. 2 foot pedals. So this one controls the microscope, it controls the zoom, the focus of the microscope, the light. The other machine here, on my right foot, controls the probe that will go into the eye. So we're going to start the operation now.
And we're going to come back to that a little bit later on. And by the way, if you looked away during any of that, don't worry, you weren't alone. 1 or 2 people here did as well. And you might have also guessed that wasn't actually Sylvia in that particular operation. But for all of us, certainly including me, who's ever wondered what exactly goes on behind the scenes prior to hospital surgery, well, that was certainly a great insight. And I hope it alleviates some of your concerns, at least. Now, the first thing I've got to say is, I noticed you weren't wearing any shoes there.
Well, we're a bit like spiders when we operate.
Right.
So I've got instruments in both hands. I've got one of my feet operates a microscope, pedal controls a microscope, and another foot operates the instrument we put in the eye to take out the cataract. If I have shoes on, I don't have any tactile feedback, so it's just easier.
You look very comfortable there, but obviously, I mean, you do. How many of these?
We also sit down for surgery. Yeah. So it's
how many of these are you doing a day?
Usually I operate all day on a Tuesday, so usually between 13 and 14 cases.
Wow, so that's quite a lot. Talk us through the process before Sylvia or the patient we saw there gets to the actual surgery part. What's gone on between diagnosis from the doctor and referral to get to you?
Yeah. So the optician or the GP will have said, look, this patient's got a cataract, they're considering surgery. They come to the clinic. We assess their vision, we do a detailed examination of their eye, including dilating their pupils. So to look inside the eye, we have to get the pupils nice and relaxed, put drops in. Once they've got a cataract, we then go through the consent procedure, telling the patient about the benefits. That's the most important thing, the benefits. Although there are risks, the risks of cataract surgery are small. We can talk about that later. But benefits, you know, if they're having problems with their vision, then we should be able to alleviate most of their symptoms. Once we've done that, then there's a process we have to do the preoperative assessment. The usual things when anyone has any surgery for their general health, but specific to the eye, we also then have to get some measurements from the eye, because the lens we put in is usually customized to each individual patient. So we find out why they want to have surgery, to improve their distance vision, their near vision, what is most important to them, and we customise the lens we're going to put into it.
And what sort of time frame are we talking about from diagnosis through to surgery normally?
Normally, okay, it all depends on which clinic. So as you've seen in the video, we've got 32 branches across London. Some sites are more popular than others. Some places have a bigger population catchment area. So it all depends. On average, I would say, you know, we have a government target to see and treat everybody within 18 weeks. And vast majority of patients will usually, from referral to treatment, will be done within 18 weeks, some a lot quicker. At the moment, to get into clinic within a couple of months and to have surgery, usually within a month of being seen in clinic.
You talked earlier on about if it's not seriously affecting your lifestyle, actually you can carry on. And is there an advice process to help people make the decision when actually it has got to that point that I need it now?
It's a very simple discussion with at the end of consultation, my usual discussion with the patient is, if you say to me, it's really affecting me, I'm miserable, I'd like my vision to be better, I'm just not happy doing the things I do, happy to give you a date for surgery. If you say, I'm happy with my glasses on, I can do most things without any real difficulty, I'll say, time to delay surgery. Because although the surgery is very safe, if you've got no real symptoms from the cataract, which a lot of patients won't, then there's no point going through that very small risk.
I just want to come back to you, Sylvia, a second, as somebody who's actually had the surgery. What for you was the point that you decided, actually, you know what, I need to get this done?
I think it was very subtle, the changes in my vision. I'd worn glasses since I was a little girl, so I was quite used to them. But I'd noticed that driving at night was beginning to be a bit of a problem. I'd had discussions with my daughter, so I was reluctant to drive at night. And I was also having difficulty at the theatre and reading text and things like that. So it was subtle, but gradually I think I just assumed that my eyesight was getting worse. Mm-hmm. But then when, obviously when I was referred to Mr. Hussain, and the cataract was diagnosed, then there was that option to improve my vision, which
you thought just might as well get it done.
Absolutely, yeah. yes, absolutely.
Well, we're going to talk a little bit later on about how it's transformed your life, and you certainly don't look quite as afraid as you were when we saw you earlier on. Looking at people who get cataracts, is there any difference in the type of person, men, women, ethnic background? Is there anybody who's has a more of a predisposition towards it?
Not really. I would say, you know, cataracts will happen to everybody if they live long enough. Some people get it earlier than others. There's other types of cataracts that we can talk about. The vast majority are age-related. Some people can be born with cataracts. Some people may get a cataract after trauma. So if somebody's had a blunt injury, so that, say for example they've had a squash ball go into their eye, that can cause other damage, but one of the injuries it can cause is from the impact, the lens itself can start to become cloudy. So there's other reasons why patients might get cataract at a younger age or need surgery at a younger age. What I would say is the population group I serve, not just ethnic minority, so we've got a large ethnic minority, but we've also got a lot of Indigenous English patients, for whatever reason, delaying surgery. A very late presentation. So today, for example, I've done 4 patients who've effectively been blind from cataract.
Wow.
So,
we could talk a little bit more about that and the fact that people do procrastinate a little bit later on. But we are going to get to that surgery very soon, and Mr. Hussain will guide us through that surgery very, very shortly. But right now we're going to take a very short break. Don't go anywhere. We will be back, so see you soon. Welcome back to the Health Show Live Surgery. Now tonight you're in for a really special treat because we're bringing you a cataract surgery. Now Mr. Bedrul Hussain, the surgeon who carried out the surgery, will be guiding us through the procedure. But we should say that the surgery footage we will be showcasing will focus purely on the detail of the eye itself at all times. So obviously we'd like to remind our viewers to be aware of this, and also our footage does contain blood, which again some of you may find disturbing. So we're actually going to start playing the VT now of the actual surgery. Now there isn't any commentary of the surgery, but Mr. Hussain is going to talk us through. So we've literally picked up from the moment we saw before.
Yeah. So we've got the close-up view of the eye now. This is the view looking through the microscope itself. So effectively, the pupil has been dilated, so you can't see the coloured part of the eye, and you're looking at the light shining back off the retina.
And how have you managed to dilate the eye?
The patient has had either drops in or a little tablet just under the skin of the eye, and then that works sort of relaxing the muscles in the eye so the pupil expands. So this is slightly atypical. Most routine surgery wouldn't mark the eye like this, would start the surgery. But Sylvia had what's called a toric IOL, which deals with her astigmatism as well, and that lens needs to be aligned specific to her individual astigmatism, so it's customized to her. So I'd marked the eye before surgery, made little marks on them, so I'm just using the pen just to make sure that those marks stay in place, and adding a couple more marks. So effectively we've got north, south, east and west on there. And then after I've made the marks, we'll start the surgery with the incision. So this is the instrument we'll be using to make the incisions. Effectively it's a knife on its side. It's called a keratome.
And how big will the incision be?
So the incision, the main incision is 2.4 millimetres. And then we make another couple of side incisions, which are about 1 millimetre in size. So I'm just marking, so if you look at the ring around it, it's got degrees just like a compass. And I'm just marking the 90 and the 180 degrees, just so we can orientate the lens once we put it in. So what you're looking at, the little opacities, little shadows in that red, are part of the cataract.
And what is Sylvia seeing at this moment, or what would a patient typically see?
So the anaesthetic, so some patients have surgery just with drops. The eye's quite mobile, but patients who are a little bit nervous, I usually like to give them the anaesthetic injection you saw earlier. That gives a deeper level of anaesthetic, and also patients don't have to worry about moving their eyes because it takes away muscle movement as well. As you can see, this eye's not moving at all. So I'm just washing the eye there. So what the patient sees is the light from the microscope, and because the light is so intense, effectively it bleaches out vision. So patients don't see very much. The anaesthetic also affects the optic nerve, so signals from the eye don't travel as well. And what patients will see, you'll ask Sylvia what she saw afterwards, but they see just a strange light show inside their eye. So this is the little knife going into the eye, into the front chamber, in front of the lens. And then we make another couple of the 1 millimetre side incisions. As you'll see, we use 2 or 3 different instruments sometimes in the eye.
And does it make any difference to the operation how severe the cataract is? Does it make it any harder? Does it make any difference?
Yeah. If you know, as I mentioned, the surgery I did this morning, we had 4 patients who were virtually blind from cataract. Their cataracts are very dense, very difficult to deal with. the ultrasound probe can sometimes have difficulty melting and breaking up the lens itself into fragments, as you'll see here. It won't do it as easily. Trying to get the opening in the lens capsule can also be difficult. So it does, each individual cataract presents its own challenges. So this is the third incision going in.
So how many incisions are you making in
generally
total?
3.
3, okay.
Generally 3 for a routine case. Now you see the blood coming, that's not coming from inside the eye, that's actually the blood vessels on the surface of the eye. You can see all the red on the white of the eye, that's those little blood vessels bleeding.
And what's the sort of liquid that you put on there?
So this is, once you cut into the eye, the liquid that fills the front chamber, the aqueous, leaks out. To maintain the shape of the eye while we do the surgery, we inject, effectively it's a little bit like egg white, very clear, transparent fluid, which stays where it is, and it maintains the shape of the eye while we carry out manoeuvres inside it. So that thick stuff is now maintaining the shape of the eye so it doesn't collapse when I introduce instruments into it. So this is a little bent needle with which I'll puncture the anterior, the front wall of the lens.
So in other words, this is, to use your analogy earlier on, this is the outer coating of the Smartie.
This is the outer coating of the Smartie, except this is sort of hundreds of millimeters thin. So it's very fragile. And what I have to try and do is get this to be make a perfect circular opening centrally within that capsule. Because if we don't make it perfectly central, perfectly round, it can affect the outcome of the surgery. And if this circular opening extends peripherally, it can actually mean we can't put a new lens into the eye because this capsule is the support structure for the new lens.
Now, for anybody actually watching this, is there anything... Now, Sylvia, you clearly don't want to watch this very much. I've noticed that.
So I have to say, Alison, this is the first time Sylvia's watched. She's not seen this before. So we have to make this, as you can see, it's...
Yeah, 'cause it must be... I mean, it's one thing watching it where I think all of us feel a little bit uncomfortable with it, but when it's your own eye, yeah, it's even worse, isn't it?
So, just trying to get this as perfect as possible, circular and central, so we don't want this drifting back in towards the centre or drifting too far outwards. So it's just drifting out a little bit, but that's fine because we're almost finished. And then the next part is to sort of inject some saline solution in to loosen up that lens substance. So you can see there's a little bit of few lines within, underneath that capsule. That's just the lens substance starting to show through. And with a little bit of saline, first I'm going to get that little capsule out.
Now, if somebody has cataracts in both eyes, how much of a gap between the eyes? Would you do them one after the other? Or?
Generally, I mean, within the National Health Service, we usually leave it. We see the patients 3 weeks later. If they're happy and the result is good, we then plan for the second eye maybe a few weeks afterwards. Right. For private patients who sometimes coming to the UK only for a week or so, 2 weeks, we'll do one eye, see them a week later, or even 3 or 4 days later, and we'll plan on doing the other eye. Some people do both eyes together. Can have some difficulties because if they have problems with one eye, you really don't want to take risks with both eyes together at the same time. So just a few little bubbles in the saline I'm getting rid of. So what I'll do now is inject some saline in underneath that membrane. So what we're doing is loosening the chocolate in the Smartie. So we're just injecting it so it lifts the chocolate away from the walls. Just need to find a nice gap, and then what you'll see is, there you go. So that's just going behind the lens to the back wall of the Smartie, just loosening that now. And as soon as you do that, it starts to come forward a little bit, but we can't have that entire lens coming forward as one go because we've only got a 2.4 millimetre incision. In all, a few years ago, 30, 40 years ago, the incision would be made much bigger, 6 millimetres, and the whole lens would be taken out as one big piece with lots of stitches needing.
I was going to say that would take a lot more time to heal.
That would take a lot more time to heal, and also vision would also not be as good because there'd be a lot of astigmatism. So the stitches could cause elongation.
So how recent is the technology that we're seeing tonight?
The technology is probably mid-80s, but to get to the sophistication we're at now, I would say sort of late 90s.
So it's been around quite some time then?
Yeah. So there are newer techniques for opening up that capsule using a laser. They're sort of undergoing trials at Moorfields at the moment to see whether or not actually it makes any difference, because it adds a lot of time to the surgery, also adds a fair expense to the surgery. And I think, to be honest, in experienced surgeons' hands, I can't see the trial showing much of a benefit, but let's see what the trial shows.
So has anybody in the audience got any questions of what they're seeing so far? Anybody who can actually watch it at the same time?
So I'm just going to tell you, so this is the ultrasound probe. So what it does three things. The first thing it does is inject saline, irrigate saline into the eye, so it keeps the shape of the eye. The ultrasound probe, so you saw one of the foot pedals I had on my foot, that controls the ultrasound. So it's just eating away at the lens substance. The way it does that is it uses very high frequency sound to melt the lens, and then through the opening in that tip of that nozzle, it then sucks out the melted lens. What I then do with the other instrument I've now done is rotating the lens inside the eye to then break it up into smaller pieces so the ultrasound probe can deal with it.
So you're using at the moment your hands, your feet, and looking
through a microscope.
Through a microscope.
Yeah.
Wow.
So thinking about it, it's actually, if you think about it, it's like driving. It becomes automatic, but if you start thinking about driving, trying to explain it, you then can't find your crunching gears.
So while you're actually removing that part, have we got anybody want to ask anything at all from what they've seen or watching?
Is that about the size you actually see when
this is the view you've got through the microscope. So this is my view as you're seeing it.
And it would be, the eye would appear to be as big as that.
Just in case, because our viewers at home can't hear. So just talking about the size now, so just if you repeat the question.
So this is the view as we are looking. So this is recording through my eyepieces as I'm looking down the microscope. So effectively I've taken out half of that lens substance, and now the other half is fairly soft, so I'm not actually breaking up into smaller pieces. I'm just going to deal with it in one piece. And then what's left behind is lots of sticky sort of string-like material, which is the outer coating of the lens. And we can't leave any of that behind. We need to remove as much of the lens as possible.
So you can actually see effectively it being sucked up there,
So the ultrasound probe deals with it very well. And that stringy material also needs to come out, because if we leave that behind, it can cause a brisk inflammatory response in the eye and affect the outcome of the surgery. So we need to remove all of that before we then put the new lens in.
Okay, while that process is going, any other questions at all? I know we've got a microphone here at the back there. Anybody? Yeah, we've just got the microphone coming over to you. There we go.
My name is Iman. I'm a student from University of Westminster. My question is regarding the recovery procedure. So how long does it take to recover from the actual surgery?
Okay. What I say to patients immediately after surgery is, hopefully, if we do surgery in the morning, by the next morning they should notice the improvement in vision. If it's surgery in the afternoon, usually by the next evening. I would say they usually take. I advise a week off work, because they're going to be sensitive to light. It is an operation; they need some recovery time. But patients are seen 3 weeks later, and pretty much it all back to normal. They'll be on drops for about 6 weeks afterwards.
So I was going to say we'll talk a little bit about the post-operative care, and I think there's somebody next to you who had a question as well.
Assalamu alaikum, Dr. Hussain. My name is Hadija, and my question is: could this type of surgery be available for people who have guide dogs or people who use walking sticks?
It depends. It depends. I think if people have got to the point where their vision is so impaired that they're using a guide dog or navigation aids, it's probably because their vision is impacted so much, probably not from cataract but from other things, usually retinal problems, where there isn't an immediate cure for their problem at the moment with the technology we have. So it's usually not from cataracts that they've got problems.
So coming back to this, it looks like you're just taking the last bits from the eye there.
Yeah, so this instrument now is just, again, you can see it's shooting out jets of water, and it's got a little nozzle in that I then use to hoover up these little stringy bits of lens that are left behind as the outer coating of the lens. When we're born, the lens grows by growing new layers on it, and then these are the outermost newest layer effectively. So it's quite stringy, it's not firm. So you can't use the ultrasound to take this. And what you're looking at now is the bare capsule on the back surface of the Smartie. And one of the risks in surgery is if that back surface is broken, the jelly that fills the inside of the eye can come forward, and if it comes to the front of the eye, that causes problems. The other problem it can cause is if that breaks during when the lens is still in the eye, the lens can drop into the back of the eye. So it doesn't happen very often, but when it does, it could mean another operation is needed.
And what about the bubbles that we're seeing there on the eye
bubbles
surface?
are just from the irrigation fluid. Sometimes there can be little bubbles in there. To be honest, if those small bubbles are left behind, it wouldn't cause any major problem. The body reabsorbs them. But we usually, it's more of a nuisance for us when we're operating because it impedes our view. So in terms of outcomes, it shouldn't affect anything. But we usually get rid of most large bubbles.
Now, we're actually watching this operation in real time.
This is real time, yes.
And this is about 25 minutes. Is that the typical length of an operation?
This is a little bit longer because it's a special order lens. We have to move it into position. An average routine operation in my hands is usually about 12 to 15 minutes. For a routine case.
And you'll sort of know that in advance because you know what you anticipate having to do.
That's the anticipated time, but anything can happen with in surgery. You know, you anticipate and you prepare as well as you can, but you know, you always have to think, you know, prepare for the unexpected.
And who else is it, apart from our camera people who are there watching, normally who else is actually in the room at the time?
Okay, so there's a scrub nurse, the nurse who helps me hand me instruments, because remember I'm looking down a microscope, I'm not looking away. I reach out and they'll pass me instruments. There's a circulating nurse who then passes anything, because the nurse who's assisting me is sterile, she can't touch anything else in theatre, so somebody else handing her things that might be needed during the time of surgery. We also have the anaesthetist who's giving the anaesthetic just in case there's any medical issues, and somebody helping the anaesthetist. So it's a team effort.
And I know, having watched this beforehand, when we complete the surgery, we'll just see the end of the operation. What happens then, the aftercare, immediately after the operation and then looking ahead?
So for most patients that I operate on, we will talk about the surgery. So here we're just putting some more of that gel in to keep the support of the eye while we then get the lens. We'll show you the lens in a second. But in terms of aftercare, I usually pop a pad on the eye. They go back to the ward, get a cup of tea, make sure they're completely happy before they go home. The nurses give them their drops, explain what needs to be done the next day, and usually they're home within half an hour of having had the surgery. So this is the lens implant that we put in. So effectively it's a little bit like a contact lens with two little arms. So the round part should be centred in the central part of the opening we saw, and the two little arms hinge up against the walls of the empty Smartie now to keep it supported so it doesn't move around.
And that's, again, the purpose of you marking those 2 points?
The marking of the 2 points is to then, once we put this lens in, you'll see I'll rotate it. This lens is special, it's got little markings on that need to be aligned in a special orientation.
Yeah.
So
and how many lenses are normally, how many are this special that you do?
At Moorfields, I think about 2 to 3% of the cases that we do use a toric IOL, so this special lens. So the lens is folded up in this little cartridge. It goes in through the 2.4mm incision, and we then push it in inside the empty Smartie case, as it were. And you'll see it's folded in half, and then gradually as it goes into the eye, it unfolds. And we just have to make sure it's inside the capsule, inside the Smartie, rather than sitting on top of it. And there's 3 little marks you can see next to the arm. There? Yep. So we just need to dial that into a special position, otherwise the astigmatism won't be corrected. And if we correct the astigmatism, then the patient will be less spectacle dependent. So I've made sure it's inside the capsule, and then in a minute you'll see I'll check the orientation, what orientation I need to put it in, and then I'll dial it into position. So more of that gel going in just to maintain the shape of the eye.
Do we have any other questions? Well, yeah, we've got a question right down the front here.
Hi. What material is the lens made of? And another question is there ever a risk of the patient developing an autoimmune response from the actual artificial lens?
Okay, so a couple of good questions. So the material, old days it used to be made out of silicon, effectively the same stuff that silicon's melted into glass. We generally don't use that anymore. There's very few silicon lenses available. The vast majority of the lenses are special types of plastic. So this one is something called polymethyl methacrylate. So it's an acrylic substance. In terms of developing an immune response against the lens itself, very unusual. It's usually due to deposits on the lens itself when it's introduced into the eye. So you saw that lens hardly touched anything in the external world. It came from the case, went into the cartridge, and then the cartridge is introduced into the eye. So very little chance for it to then get any other sort of outside proteins on it. And that's what usually develops an immune response.
And all through this, Sylvia, you were just...
Completely oblivious.
Completely oblivious. Did you feel any pressure, any sensation at all?
No. Absolutely nothing. No.
As I said to one of my patients last week, I hope you found that as relaxing as I did, because they fell asleep. Which is actually a worry, because I've had a couple of patients who start dreaming and then they suddenly try and get up because they've woken up. They suddenly wake up. So if they start snoring, I usually nudge them to make sure they're awake.
That's a pretty good sign that it's not too painful, isn't it?
No.
Yeah. Okay, so there's a measuring instrument. Anybody else? Any other questions? Yep, just behind.
Yes, hello. I was wondering, going back to your question about the lens, is there ever a case where the patient would feel the rotation from it, as you described it, kind of close to a contact lens?
No. So this is what patients are worried about. They're worried that the lens will move, that the lens will fall out if they start rubbing their eye. Once the lens is inside the eye, if it's inside the capsule, inside that Smartie shell, patients shouldn't feel it. So
there's no situation where they would need retouch up or surgery like that?
In terms of retouch surgery, they won't, but what can sometimes happen is the back of the Smartie shell itself can start becoming a little bit cloudy, and if that happens to about half of all patients by about 5 years, it looks as if the cataract's coming back to them. And what we can then do in clinic is we use a little bit of laser to polish up the back surface of that capsule, effectively breaking the capsule. So making a little hole in it, and then that should be the last part of cataract surgery. So generally, once they've had cataract surgery, that should be it.
So we're just coming to the last part.
So
while you weren't looking there,
I've rotated it.
You were just rotating it a little bit.
And then we put the instrument back in to take out that jelly substance,
right?
Because we can't leave that in the eye; that will cause problems. So we try and take. There you can see little bits of it coming out.
Yeah.
So it's usually transparent, but once you start sucking on it, you can see little shadows. So there, I'm just taking all of that jelly substance out. And you can see, so
it's just incredible what you can do.
So generally, for most patients, we don't put stitches. So these incisions are so small, the self-sealing. So right at the end of surgery, what you'll see is I'll use a little injection cannula. What I'll do is I'll inject a little bit of saline into each incision. What that does is swell the cornea, the clear window at the front of the eye, so it sticks together. So even if there's a small leak, it usually sticks together, and by the time it's the saline gets reabsorbed, healing's already starting to take place. So just making sure all that jelly substance...
Just getting the last bit out.
Yeah, last few little bits of jelly.
I guess that's one of the reasons to have the different incisions, so you can approach from different styles.
Exactly. And also just making sure that lens is centred. We want that lens as central as possible.
Well, we're coming to the very end of this, and we're nearly out of time, so I just want to come back to you, Sylvia, really just to close this off. You've had the operation. What would you say to somebody who was maybe procrastinating about... I'm not sure if we need the microphone for you, but we'll bring it to you just in case. What would you say to somebody who's procrastinating?
Don't hesitate at all. Absolutely, don't hesitate. The next day, I took the dressing off my eye, and I couldn't believe what I could see through that eye. My worst eye was now my best eye. And so what better recommendation could I give, really?
And now what's going to happen about the other eye? You're going to have that done?
The other eyes.
We've done both.
You've done both now?
We've done both.
Yes.
So I think one of the first things that Sylvia said after we'd done her second eye was, well, I'm glasses free for the first time in 55 years.
Yes, absolutely. Absolutely. Don't wear glasses anymore for the first time since I was a little girl. So, and my vision is so much better. Fabulous.
And all that fear you had beforehand?
Absolutely. Well, I think the best way of showing how I felt about that was I came out of theatre having had this surgery, and I just went back into the waiting room where everybody else was waiting for their surgery, and I just threw my arms open and said, there's absolutely nothing to worry about.
And she came back for the second eye. I think that was the most telling. She came back for the second eye.
Absolutely fantastic. That's absolutely brilliant. Well, I think that deserves a round of applause for Sylvia for having the bravery to do it, and also for Mr. Hussain here. Fantastic.
So in terms of the surgery here, all we're showing is just checking that the incisions aren't leaking. So that little bit of blood is coming from the surface of the eye, not from inside. So I'm happy, actually. That'll stop in a few seconds. So I'm just injecting, and you can see it go a little bit white, the cornea, the clear window, and just checking the pressure. It's not overinflated like a balloon. So it stands at normal sort of eye pressure. And then we're done.
Absolutely amazing. Absolutely amazing. Well, I certainly hope you watched every single moment of that, because it was pure artistry to watch that and look at that. The out comes the clamp, and that's it.
I think we're on a little bit of a loop here.
I think we just want to show your skill here by repeating it again. But again, as you say, those sort of things, they're so minute, they just heal automatically.
So for the vast majority of patients, no stitches needed.
Fantastic. Well, thank you very much indeed. That really was absolutely amazing. And what an incredible skill and precision. And I don't mind saying I was feeling a bit worried for Sylvia, let alone anybody else. But after watching that surgery and seeing how quick it was, I certainly feel a lot relieved as well. Now, hopefully none of us will need a cataract surgery anytime soon. But if you do, it's certainly very reassuring to know that there's a dedicated team of surgeons working in hospitals such as Moorfields Eye Hospital, should you ever need their services. Well, that's it for tonight. Thank you again to Mr. Hussain, to his wonderful team there at Moorfields Eye Hospital. And as always, thanks to our studio audience and to you at home for tuning in. If you have any questions about tonight's show, please do get in touch, healthshow@islamchannel.tv. Until next time, thank you, good night, and assalamu alaikum.